polyps are fairly slow-growing beasts. It can take anywhere from 10 to even 20 years before you can grow a polyp of sufficient size, and then that polyp turns into a cancer. So you have a very large window to intervene, hopefully, before someone's polyp turns into cancer.
One of the great advantages we have in being able to prevent colon cancer is that we now largely understand the natural history. Almost 100% of colon cancers begin with a form of a polyp. For years, we thought there was really only one form of precancerous polyp, the adenomatous polyp. And there was a sequence going from small polyps to larger polyps to dysplasia, abnormal cells in the polyp, eventually to an early cancer and then to an advanced cancer. And that's really fundamentally the key to colon cancer screening, because if we remove that precancerous polyp, we actually prevent that progression and prevent the development of cancer, not just find cancer early. Screening for colon cancer has been really one of the great public health triumphs of the past decade. We have seen a 43% decline in colon cancer mortality from the peak. And a great deal of that decline in mortality has been driven by a 30% decline in the incidence of the disease that occurred between 2000 and 2010, as well as some decline before that. Almost all of this decline in incidence, we believe, is due to screening and the detection and removal of polyps that have the potential to become malignant. If we remove the polyp, we actually prevent the cancer. This is work that was done years ago by Sidney Winter and his colleagues in the National Polyp Study that proved the concept that if you remove polyps, you prevent cancer. We've now translated that to public health action and are seeing a really impressive decline in mortality and incidence, largely due to screening. You know, many people wonder, if I'm living a healthy lifestyle, why do I have to put myself through something like collecting a stool specimen at home or going through a colonoscopy? And the answer to that is compelling and it's clear. Virtually 80%, 4 out of 5 people who develop colon cancer do not have an identifiable risk factor. Unfortunately, this is the second most common cause of cancer-related death in the United States. It's third in men, it's third in women, and it affects people who are otherwise perfectly well and perfectly healthy. Listen, being healthy, being physically active, avoiding tobacco, high fruits and vegetables, avoiding red and processed meat do reduce your risk for colon cancer, but they do not eliminate your risk for colon cancer. We have such a wonderful opportunity through screening to prevent colon cancer through polyp removal or to find it colon cancer while it's completely curable. So regardless of how healthy a lifestyle you lead, it's still part of a healthy lifestyle to be screened for colon cancer when you hit 50.
Unlike other screening tests, we have a lot of options for colorectal cancer screening. The idea would be to have a test, whether it's a fecal occult blood test or fecal immunochemical test or colonoscopy, that allows you to detect a polyp before it turns into a cancer. So colonoscopy is the probably most obvious and easiest choice. Where they look inside your colon and voila, they see a polyp and they can do a biopsy and remove it before it has a chance to turn into any cancer. Fecal occult blood tests and fecal immunochemical tests work off the idea that polyps bleed intermittently, and so do cancers. So that blood gets detected in the stool. That prompts, if it's positive, then the person goes on to get a colonoscopy. Same process applies. They either find a polyp and remove it, or as the case might be, you might find a cancer early enough where treatment has a much better outcome than if you let cancer grow to a much later stage.
There's a high level of agreement about colon cancer screening guidelines, and there are several groups, of course, who author guidelines. Probably the two that are best known are the guidelines published by the United States Preventive Services Task Force and the guideline that's published by the American Cancer Society, the Multi-Society GI Task Force, and the American College of Radiology. And at the core of the guideline, the agreement is virtually 100%. that the two most important and available screening strategies for average risk adults, 50 and older, is to have either a colonoscopy every 10 years, one colonoscopy every 10 years, assuming the first one is normal, or to use a high sensitivity stool blood test that must be done every year with a colonoscopy for those people who test positive for the presence of blood. When you're embarking on a screening program for colon cancer, it's important not to skip step one. And step one in a colon cancer screening program, whether it's a national program, a state program, or just going on and one-on-one with a clinician and their patient, is the assessment of risk. That means that you need to assess the personal history in the patient. So step one of every screening program is to assess risk. We should not be screening people at above average risk with guidelines that were written for people who are at average risk. We have really this extraordinary strategy in cancer prevention by finding precancerous polyps. It's also true that survival correlates with the stage of cancer. So people diagnosed with early cancer, stage A cancer, that has not penetrated through the wall of the colon, achieve nearly a 100% survival, certainly well over 90%. Whereas if it penetrates through the wall, or if it has spread to the lymph nodes around the colon, or in the final stage, if it has spread to distant organs, like so many other solid cancers in adults, the survival rates go down dramatically. We know that the likelihood of surviving a cancer diagnosis strongly correlates with the stage of the cancer. So we really have two opportunities here to both to remove precancerous polyps and prevent colon cancer, but we also confer a great survival advantage if we find the colon cancer while it's localized. In fact, the 5-year survival for localized colon cancer is 90%. If that colon cancer has spread regionally, meaning through the wall of the colon or into local lymph nodes, there's a substantial decline in survival rates to only 67%. Still great hope there, but not nearly as advantageous as finding it while it's local. Unfortunately, like so many other solid tumors in adults, if the cancer is distant and has spread to distant organs, the survival rate is quite low. In fact, only 5% for individuals with advanced metastatic colon cancer. So our best advantage here is to both remove those precancerous polyps or to find the colon cancer while it's localized when the cure rates, in fact, are very high.